welcome everybody to the last live session of day 3 of our Wellbeing Week. I hope you've all managed to have some time today to perhaps grab a session or two, or even yesterday or the day before. If you haven't had a chance on Monday or Tuesday, the sessions that have been recorded are all available on our platform, Hey Summit. So please make sure you access those in your own time and enjoy them. We had some great sessions just today on sleep. We had ones yesterday on fibre and protein, and a fantastic session today about minimalism and money. So, lots of things available and for you around your mind, life and body. Well, I'm going to get started since I've seen everyone's ticked up into the lobby. So welcome to Wellbeing Week once again. My name is Kim Hamrosi. I'm sure many of you have seen me already over the last couple of days, and I'm here from the Corporate Mental Health Alliance. It's actually great to be with you today. And this week, as you know, is all about creating space to reflect, reset and support our mental health, both at work and beyond. If you're interested in learning more about the Alliance, you can see a QR code behind me. Please feel free to scan that or visit cmhaa.org.au. We've got lots of great resources that you can access in your own time. And I also want to thank MetLuma today for their session and for making time. Thank you, Dr. Nick, and MetLuma for making time today and making these conversations possible. We know around menopause, there's lots of conversations going on around at the workplace, and so we're very grateful for you today coming along and talking more about the impact of mental health and menopause. So just introducing Dr. Nick, for those that may or may not have already seen her on some of the sessions we've had in the past, is Dr. Nick is an integrative general practitioner at MetLuma with a special interest in women's health. She is very passionate about walking alongside women through the menopause transition, offering evidence-based holistic care that supports both their physical, emotional and hormonal well-being during this significant life stage. We're so pleased that you could be here with us today, and I hope that everybody enjoys the session. Just reminding everyone, please be interactive. If you've got any comments or questions, please post them in the chat. Use the reaction buttons if you love something that's said. So it's good to know that somebody's out there listening. Thank you for the lovely hearts. Okay, over to you, Dr.
Amazing.
Nick.
Look at everyone picking it up so quickly. Thank you, Kim. Yeah. Thank you so much, Kim, and thank you to Kirsten and Hannah for the epic effort of what is the Corporate Mental Health Alliance Wellbeing Week. It's a privilege and an honour to be here sharing knowledge with you. There is an acknowledgement of country in the chat there. I am coming to you from Darkinjung land and just want to acknowledge First Nations people for the care of our country and those on the call in particular. I also want to acknowledge that when I'm using the word woman in this presentation, I'm referring to assigned female at birth. Not all people assigned female at birth identify as women, so we are open to a range of diverse experiences. Thank you so much for giving up your time this afternoon. I'm sure you are all extremely busy. So what we're going to talk through today is a little revision of our menstrual cycle and where does menopause sit in that. I'm then going to overview what I'm seeing as presentations for menopause, just as a kind of refresher. You may know some of it, you may not. And then we will dive into the specifics of how it's affecting mood and sleep in particular and what you can do about it. So hopefully this is helpful. Mental health is extremely passionate to me. It's what I see really frequently, and the impact on women through the perimenopause and menopause phase can be really quite significant. Also a bit of a trigger warning that if this is triggering for you, please do seek assistance, whether it be through your local medical health care provider, your psychologist, your EAP, through Lifeline, Beyond Blue, Black Dog Institute, a range of resources out there for mental health support. But starting conversations is one of the biggest steps forward so that we can find validating and safe spaces to help women. So let's go right back to the beginning of what is your menstrual cycle. So 28 days roughly for your menstrual cycle. We call day 1 the first day that you're bleeding. Most of the time, most women bleed for about 5 days. And then what happens next is the follicular phase. So that's where estrogen starts to rise to grow the lining of the womb again. There's then ovulation, which happens around about day 14 to 15. That happens as a result of what we call an LH surge. So that LH surge comes from the pituitary to tell the ovaries to drop an egg. And then after that, there is a change in the hormonal balance where estrogen starts to fall a little bit and progesterone rises to make the lining of the womb really plump and thick, ready for a pregnancy. And then if pregnancy doesn't happen, then we go again around to bleed. The reason why I bring up the physiology of the cycle is that when we're hitting perimenopause and menopause, there is a change in that regulatory pattern that becomes quite irregular. So menopause in definition is the ending of reproductive functioning. For most women, it's 12 months after their last menstrual period. So it's one day in a woman's life, 12 months after her last menstrual period for most women. For some women, it can look a little different. For example, if you have surgical menopause or if you have chemotherapy, then you're thrust into menopause the very next day. If you've had a hysterectomy and you still have your ovaries, you will transition through the menopause phase at your natural time. It just becomes a little bit tricky on knowing when that is because you're not bleeding. It's in these kind of limited circumstances that we might do a blood test to check if you're menopausal or not. But for the most part, menopause is diagnosed from symptoms and also that 12 months after the last menstrual period, once you know when it is. So the average age for menopause in Australia is 51. For Asian and Middle Eastern populations, that drops to about 47 to 48. But the thing that we're most interested in, aside the menopausal day, is this concept of the perimenopausal transition. So this is where instead of that nice LH surge happening once a month, it becomes a bit erratic. So ovulation starts to become a bit erratic. So therefore that your hormones can feel literally like a roller coaster. So estrogen can be fluctuating very, very significantly up and down, and progesterone is on a general decline. And that perimenopausal phase can last for up to 4 to 10 years for a woman. So we need to be talking about perimenopause and menopause for women in their 50s, clearly for women in their 60s as well, but also for women in their 40s and for some women as early as their late 30s, particularly if they're of Asian descent or Middle Eastern descent. It also depends a little bit on when your mum went through menopause as to when you will go through menopause. So that menopause average age in Australia, 51, 47 to 48 for different populations. Early menopause is classed as under the age of 45, and premature ovarian insufficiency, which is where menopause is premature and ovulation is stopping premature, is under the age of 40. So you can see there's a range of age groups that we need to start to having these conversations around menopause and symptoms and particularly mental health. So I just wanted to flag that most people associate menopause with hot flushing. That is definitely not what I see walking through my door. I classically see someone like Sarah, who's 46. She's presenting to me with fatigue. She's generally exhausted and she can't sleep. She thinks she's going crazy because she can't remember anything and she's really worried that she's got dementia. She can be parenting up to aging parents who require support. She's either got young children or teenagers, and she's working full time, whether that be in a paid capacity or in a volunteer capacity or a caring capacity. And Sarah is generally, for the most part, at her wit's end and considering dialing down her work or quitting her job because of she just doesn't know what's going on. So I just want to normalise that this is kind of what I'm seeing in my workplace with menopause presentations, and it's definitely what we're seeing in terms of the data that we're collecting here at Metaluma. So the reason why I bring this slide up is one, for awareness. The range of symptoms that can happen in perimenopause and menopause is really quite broad. If you speak to some people, it could be up to 100 symptoms. If you speak to others, it's 20. It's really important that we don't sweep everything under the menopause umbrella and you get appropriate care to make sure that nothing else is going on. And it's also important that these symptoms are recognised so that we can start to connect the dots, because basically if you're presenting with symptoms, then you're perimenopausal. The definition of perimenopause medically is a change in menstrual cycle by more than 7 days for consecutive days. But I'd have to say I'm seeing some of these symptoms even well before the change in the menstrual cycle. So some of the physical symptoms are can be hot flushing. Ones I see commonly is joint pain, changes in headache and migraine patterns. So if you've had stable migraine patterns and they start to flare again, weight gain because of changes in estrogen regulation of insulin, dry eyes, dry mouth, breast tenderness, and the changes in the menstrual cycle. And then if you flip over to column 3, those that are often not spoken about and often not brought up, but can be really debilitating. And the reason why I bring this up is because they can affect mental health. The physical symptoms can affect mental health. You know, if you're not sleeping well, if you've got joint pain, if you've got changing in body shape that you're not comfortable with, and the symptoms that are affecting the genitourinary area, needing to run to the toilet all the time, vaginal irritation, vaginal dryness, dropping libido, impact on relationship, they can obviously impact mental health as well. And then lump that into the middle, that the changes in the estrogen and progesterone and how it's regulating our brain chemicals can contribute to feelings of anxiousness, low mood, the brain fog, dropping self-esteem. Irritability and rage is real, like, you know, everyone's an a-hole, and that is a real thing in perimenopause and menopause. You know, this is why we need to be talking about perimenopause and menopause and the impacts on the mood. The reason for that is that not only for the physical and genitourinary symptoms, but estrogen and progesterone are very powerful regulators of brain chemicals. So estrogen helps regulate dopamine and serotonin. So serotonin, our happy, feel calm hormone. Dopamine is the major hormone in our frontal lobe, which helps us with executive functioning and memory. And it's also our reward hormone that makes us feel good about ourselves. And progesterone is generally calming on the brain. It works on what we call GABA receptors, which are a bit like baby Valium. So they kind of calm everything. So you can see, excluding the pun, that, you know, we can end up a bit of a hot mess with these roller coasting hormone changes because of the impact they're having on our physical bodies. And because of the impact they're specifically having on our brain and our brain chemicals. So what is the literature saying around the impact on mood? So we've worked very closely with Monash, the Her Centre at Monash University, are very passionate around women's health and the impact it has on mental health. Our UMA-40 scoring system is a combination of those physical symptoms and genitourinary symptoms we just described. And we've worked with them to adapt the MENO-D, which is a specific scoring system for menopause depression, because that can look a little bit different to normal depression. And we've blended those to come up with 40 symptoms where you can screen yourself as to whether you are at risk or having symptoms of, you know, menopause, the impact of menopause on mood or menopause depression. Because if you've had a history of depression or anxiety in the past, it's more likely to relapse in perimenopause or menopause. So you might find that the medication if you're on medication, the medication you're on is maybe not working so well anymore, for example. If you've had a history of postnatal depression, you're more likely to struggle with mood and mental health issues through perimenopause and menopause. Their literature said that 40% of women are presenting to GPs purely with anxiety and depression when it's actually perimenopause and menopause, independent of any other symptoms. And this is the last circle there is the one that I clearly get really sad about, is that the completed suicide rate in women in Australia is highest at the age of 45 to 54, and we have to think that the hormones are playing a role there. And once again, if you are struggling, help is out there. Please reach out for it. There is no need to struggle. So, you know, those statistics are quite significant, and that is why we must be talking about it. So then they went on to do a study on the impact of treating perimenopausal women with hormone replacement therapy, because what's often happening here is that women are given SSRI medications, and sometimes that may be appropriate and sometimes that may work, but a lot of the times it actually doesn't kind of cut the mustard in terms of treating their symptoms, because there's a hormonal play here. We're also working with another group on developing a digital CBT, peri-specific CBT program, and that can be a powerful treatment tool as an adjunct to hormone replacement therapy if you're struggling with mood through the perimenopause and menopause transition. So they did a trial where they treated perimenopausal women with positive MenOD scores. The first line treatment was not SSRIs, it was menopause hormonal therapy. And immediately they found a 60% improvement in symptoms with far less side effects that the SSRIs can give, such as weight gain, sleep disturbance, and low libido, which can be already things that are going on in perimenopause and menopause. Where does sleep fit into this? So let's just, I mean, it sounds like you've already done a great session on sleep, but let's do a quick kind of 101 of the stages of sleep and the impact that the hormones are having on your sleep. So stage 1 is light sleep. Stage 2 is where you're drifting into from light sleep into deep sleep. You want to be spending about 50% of your time there because that's where recovery is starting to happen. Stage 3 is deep sleep, and you want to be spending about 20% of your time in deep sleep because that's where tissue repair happens and immune support happens. And then stage 4 is that REM sleep, which is really important for our cognitive function. So about 20% of time in REM sleep because that is where we lay down our memories and it helps us regulate our mood. So we have a partnership with Garmin, and if anyone who's interested in tracking their sleep, I think it's an interesting experiment to see what variables happen through your day or the night to impact particularly your deep sleep and your REM sleep, because they're going to have an impact on mood and memory and cognitive functioning. But the hormones play a part here too, because the literature shows that at least double the number of women really struggle with sleep through the perimenopausal phase. I actually think that's probably a bit higher. Sadly, that will continue and increase, and triple the number of women will struggle with sleep, after their menopausal day. And the impact on cognitive function is significant. 2/3 to 3/4 of women saying that they're brain foggy, having difficulty concentrating, and struggling with symptoms and concentration at work through the perimenopause and menopausal phase. And we need to be talking about this and supporting these women so that they, because they're often at the prime of their life in terms of their career trajectory. And it's something that often as an institution, we don't want to lose their amazing wisdom and knowledge. So what are our hormones doing to our sleep? So basically, estrogen is a particularly powerful regulator of sleep architecture. So we often find that women are waking at kind of 2-3 o'clock in the morning, just being awake, and they don't really know why, because of those estrogen fluctuations. As I said, progesterone is a powerful regulator of GABA, and that is very, very calming. So that declining in progesterone will start to affect your sleep. Mixed into that, there can be cortisol affecting sleep because of stress levels, and of course then hot flushing affecting sleep as well. Some people will find that their sleep is more disturbed just prior to their period coming along because of progesterone sensitivity in the brain. And it's these times where you just may need to be a little bit more diligent with your sleep hygiene around, phones before bed and caffeine and alcohol and those types of things. MHT can help here too, so menopause hormonal therapy. There is a particular form called micronized progesterone, and that is very calming. So if you're on micronized progesterone, make sure you take it at night because, as I said, that is very calming. About 4% of women will have sleep apnea as a postmenopausal woman, and it presents a little bit differently. So if you are snoring and particularly gasping and waking tired, and your loved ones are bothered by your snoring, make sure you're getting screened for sleep apnea because that's something we don't want to miss for a whole range of reasons. Why do we want to sleep well? Because it impacts our mental health. So we know that if we sleep well, there are reductions in anxiety and depression. It reduces our risk of cognitive decline and improves our cognitive functioning and executive learning. And there's a range of physical benefits to sleeping as well. It reduces our risk of cardiovascular disease, of weight gain, and improves inflammation and repair. And everything comes from sleep. When I'm speaking to women, I'm like, if you're not sleeping well, it's so hard to do everything else. It's hard to show up for work. It's hard to find enough energy and time to exercise. It's hard to put some nutritious strategies into the day because you just want to be grabbing for sugar and coffee in a quick hit. So if I could mandate 2 things in public health, I would mandate time for people to sleep well enough and time for people to move well enough. So that's what I would do if I was kind of running for president. How do we optimize our sleep? I think the take-home message here, I mean, you know, most of the things are kind of cool, dark environment, reducing the scrolling before bed if you can. But I think the interesting thing here is that sleep is actually a 24-hour process. So when we wake up, cortisol rises to help us get up out of bed and get through our day. And then as we get into the end of the day, the dropping of the setting of the sun gets melatonin released from the back of our eyes, and melatonin helps us get off to sleep and stay asleep. If there is, however, dysregulation between this nice cortisol melatonin rhythm, then that will affect sleep function. So anything you can do through the day that will help regulate your cortisol and not keep it so high. Early morning light can be helpful, meditation, exercise, depending on the time. Some people find exercise in the morning very helpful. Sometimes exercise at night can be too stimulating. Anything that can help regulate cortisol through the day and then facilitate melatonin at night can have an impact on sleep. And again, these are the things that might be interesting around wearables, right? If I stop coffee at a certain time in the day, what happens in my sleep? If I spend 10 minutes with my feet in the grass in the morning, what happens to my sleep at night? So I think there's interesting experiments with very simple free things you can run of how you can optimize and change your sleep. Just a little call out on trauma here. I think this is something that is definitely not spoken about. So a 2025 research report showed that those women that had experienced trauma, either currently or in the past, were significantly more likely to really struggle through the perimenopause and menopause phase. They found that high ACE scores, so adverse child events, were associated with poor memory, difficulty sleeping, difficulty concentrating, bladder issues, chronic pain, anxiety, and depression. So I just want to call that out. And again, a trigger warning that if you are struggling, please seek appropriate help to get trauma-based therapy. That again, that is something that needs to be spoken about around menopause and mood, because we're looking at changes in hormonal fluctuations and brain biochemistry that's impacting mood. But if we're wrapping trauma around that, then that's a little bit more complicated. And these are the cases where MHT can be helpful, but often not the biggest bang that we're seeing, because it's a little bit more complex. So that's just more of an awareness piece. So where does MHT fit into this whole circumstances in order to support mood? Clinically, I just find it can be amazing for many women. So MHT, menopause hormonal treatment, it's changed from HRT, hormone replacement therapy. They wanted to get rid of the replacement, but I still stumble over it, HRT, MHT. So just to give you the background for those who don't know, there was a big study in the early 2000s called the Women's Health Initiative, literally blew hormone replacement therapy out of the water, and prescribing fell off a cliff. Basically, it took one form of hormone replacement therapy, which is old and we don't use it very much anymore, gave it to an older population, misrepresented the breast cancer and cardiovascular risks, and spread it across the world and generalized it to all women, saying that hormone replacement therapy was bad. Since then, we've changed the way in which we deliver hormone replacement therapy. So it's now what we call body identical, the same molecules as your estradiol and your progesterone. We've done a whole lot more research, both on that data set and with new therapies. And the pendulum has swung quite the other way. So it's definitely the best treatment for symptom control. I definitely see improvement in hot flushes, in sleep, in mood, in general irritability, in dryness, in vaginal symptoms, in urinary tract infections, in libido. So definitely the best treatment for symptoms. It is now been shown to reduce fracture risk, and it's the first line treatment for what we call osteopenia, so thinning of bones before osteoporosis for women up to the age of 65. If started within the first 10 years of your menopause day, it actually reduces your cardiovascular risk, so a 50% reduction in developing cardiovascular disease and a 30% reduction in dying. We think it's probably going to reduce dementia risk. The studies are still a bit out on that, but the early studies are looking promising on the newer therapies for reducing dementia risk. And as I said, I can see so much improvement in many symptoms for MHT. So what are the misconceptions for MHT? It does not cause breast cancer. So we're currently quoting the excess risk of about 1 in 1,000 women over 5 years because of the new ways we're delivering it and more research being done. In fact, if you're just on estrogen alone, which you can do if you don't have a womb, it actually reduces the breast cancer risk. It does not cause cardiovascular disease, it actually prevents it. There is a slight increased risk of blood clots, about 2 per 1,000 women over 5. But if you take estrogen transdermally, which means as a patch or as a gel, rubbing it on your arms or legs, then that completely negates the clot risk. It's generally well tolerated, and if it's not, it's usually because of kind of styles and doses and brands, and we just do a bit of fiddling around to find something that suits you. As I said, if I was kind of running for Prime Minister, I would mandate sleep and exercise as public health initiatives for everyone. And I think you can't talk about mood without talking about exercise. So we know that 150 minutes is the standard guidelines, but going back to what I said before, if you're really struggling with sleep and symptoms, then it's hard to fit exercise in. So I would say to you, consider, assess what your symptoms are. Do you need to consider going on MHT if you think that is right for you? Because it may just drop the water level on your symptom load, get you sleeping better so that you could then start to move more. The gold standard is 150 minutes, as I said, but any movement is great. However, to be specific for perimenopause and menopause and mood, walking is not enough. We need to be building your muscle and improving your bone density. If all you can do is walk, amazing, then just walk. Even if you're just putting on your shoes and walking to the letterbox. But exercise has been shown in the SMILE trial to have as much reduction in depressive symptoms and ADHD symptoms as medications have. So if we can line our ducks up enough to move our bodies, then it is the best thing for helping with mood and preventing chronic disease, particularly through perimenopause and menopause. Building muscle, as I said, is crucial through perimenopause and menopause, and the O'Neuro program is based off the Lift More trial, which is where women were recruited to lift heavy. So twice a week they lifted for 30 minutes, high intensity repetitions, so 5 sets of 5 repetitions of greater than 85% of their maximum lift. And that was shown to improve bone density almost as good as medication to reduce your fracture risk. So what are my take homes for today? First and foremost, if you are struggling with any kind of mood symptoms or mental health issues and you are anywhere from 35 to 80 or beyond, there may be hormones at play there. So do your UMA40, you can scan that QR code and that will help you assess what your symptom load is. You will get a report that shows what your physical symptoms are, but it will also tell you your MenOD score so that it helps you understand what are your hormones impacting your mood, because sometimes it can be so hard to tease out between work and parents and kids and stress. It can be really difficult, but awareness is step number 1 and you don't need to struggle or suffer anymore. Then if you consider it, if you're interested, speak to someone about whether MHT is a treatment option for you, particularly for your mood and sleep. Sometimes it's just the thing that I do is we write it in pencil, we try, do your UMA40 again, and if 2 months time you've improved, then your symptoms are probably perimenopausal or menopausal, and we can continue to assess that. Optimize and prioritize your sleep, particularly if you're sensitive coming into your cycle. Maybe think about your sleep hygiene and what are 1 or 2 things that you might be able to shift to improve your sleep hygiene, whether it be cortisol related or melatonin related in the evening. Try to move your body, but try to sleep first, because it's really hard to move your body if you're really tired. And most importantly, seek psychological support if you are struggling with your mood. MHT is just one form of support here that can be extremely helpful. If you can't find the right GP or the right psychologist that can help you through this perimenopause and menopausal phase, we're definitely here at Metaluma to help you, or find someone else who's going to connect the dots for you and listen, because as I said, that it's the mental health in place for me can be heartbreaking, and there is no need for you to struggle. And just that little note on trauma, that if you have had a incidence of trauma as a background, it's probably more imperative that you're seeking some psychological support at this time, because it can just ramp things up a little bit. And I think that's it for me, Kim.
Dr. Nick, thank you so much. Unfortunately, you're frozen for most of us for the last couple of slides. Yeah, we can hear you.
Did I freeze like picking my nose or something, or was it?
No, no, you've just you've got you're not doing anything terrible, but
right.
but you have frozen on the screen, and I'm not sure whether you had more slides, but we're still on the one that says, where does medication and menopausal treatment fit?
Okay, I have really frozen, haven't I?
Yes,
but should I jump out and go back in, or?
If you've got if people want to ask a couple of questions and you're willing to stay on, if you want to jump out and come back in, we would be more than happy.
Maybe I'll just
a few minutes. No, now we've lost Dr. Nick entirely. Sorry, folks. Hopefully she'll come back in a minute, and we might be able to get to a couple of questions if people want to stay on. I know it's a busy day for many of you, but can you share the QR code in the chat, as I don't need to jump off? I can actually give you the link to the UM40 and Metluma's site in the interim, so that we can do, which I think's already been done.
I was about to say, I can see Katrina's. Thank you, Katrina. She's already shared the
thank you.
Metaluma.
Well, folks, it's been a day of unstable internet connections all around. Too many people perhaps using air cons, or I don't know, electricity, or wherever we might be. So apologies that Dr. Nick has frozen, but I'd like to say thank you to everybody today for joining the session. It's been terrific having on here. I'm sure Dr. Nick will be through. She may join us in a minute again. I don't know. We might give it a second if she wants to. But there is a recording available of today. I might see whether there's a couple of the slides at the end that she might be able to make available to us, and we would put that up on the Hey Summit platform. So if you need to jump off, I hope you enjoyed the session and you got a lot out of it. There'll be a recording available by tomorrow morning. And then also don't forget all the other sessions. Sleep. Had a really great session earlier today on sleep. The recording will be up tonight. Please make sure you get an opportunity to
there's another menopause session tomorrow as well.
Yes, of course.
With Dr. Nick as well. So